Hey, Appy.
Oh, hey, Sai. Fancy seeing you here at this hour.
Yeah, I came in search of you.
How so?
I thought we'll discuss solid neoplasms of pancreas together.
All right, you take the first part. I'll take the second.
Hi guys, today we'll be discussing the topic of solid pancreatic neoplasms. Solid pancreatic neoplasms are predominantly three in number. The first one being pancreatic ductal adenocarcinoma. The second one is pancreatic neuroendocrine tumor. Third one is the pancreatic lymphoma. Now, we'll start with pancreatic ductal adenocarcinoma. Pancreatic ductal adenocarcinoma, which is known as PDAC, is most commonly seen in an elderly male who is a smoker and an alcoholic, typically seen in the background of chronic pancreatitis. It is most commonly associated with KRAS more than P53 mutation, and most common location is the head of the pancreas. The important point to note is that any head PDAC will present to you early, because even if the pancreatic head PDAC is smaller in size, it will cause an early obstruction of the CBD as well as the pancreatic duct, causing its dilation, and that is known as the double duct sign. However, a tail lesion, because it is not going to obstruct either CBD or a pancreatic duct, it will present when the size is enlarged, when it is going to metastasize. So it is presenting late and the survival rates are less, right? Moving forwards to the clinical feature, patient will typically complain of an abdominal pain with a weight loss. If it is causing a pancreatic duct obstruction, patient will come with acute pancreatitis. I've explained it in acute pancreatitis video also, that any patient aged more than 40 years coming to you with acute pancreatitis, always do a CT to rule out PDAC. So now we understand why we should do that CT. So if it is causing a CBD obstruction, patient will present to you with jaundice. The PDAC can also invade the superior mesenteric vein and cause a tumor thrombosis of the superior mesenteric vein, right? Now we'll move forward to look at the approach to PDAC. How do we approach a case of pancreatic ductal adenoma? Whenever you have a clinical suspicion of pancreatic ductal adenocarcinoma, we do ultrasound, which is the first line of investigation. Even on ultrasound, you are feeling that it is a malignancy, go ahead and do a dual phase CT, which includes a pancreatic phase and a venous phase. On a dual phase CT, if you are able to detect a pancreatic ductal adenocarcinoma, it is a radiological diagnosis, and hence you directly move forwards to the treatment. However, if you are not able to see PDAC on a dual phase CT, it means the mass can be iso-enhancing. So go ahead and do an MRI with an MRCP with contrast. Even on an MRI, if it is iso-enhancing and hence you're not able to look at a PDAC, go ahead and do an US guided biopsy, which is the most sensitive investigation for detection of a pancreatic ductal adenocarcinoma. Now we understood how to approach. Now we'll look at various imaging features of pancreatic ductal adenocarcinoma. Starting with the ultrasound. On an ultrasound, you can see an ill-defined hypoechoic mass with a dilated pancreatic duct, which on placing a color box, you will see minimal vascularity. Sometimes you might not be able to see any vascularity within it. Moving forwards to the CT, we do a dual phase CT, which includes a pancreatic phase and a venous phase. Pancreatic phase is taken at 40 to 45 seconds, whereas a venous phase is taken at 70 seconds, right? Why do we take a pancreatic phase? In the pancreatic phase, as the name suggests, pancreas is maximum enhancing, but however, PDAC being a hypo-enhancing mass will be hypo. Because of this difference in the contrast between the pancreas and the mass, it is a phase which is best to detect the lesion. Coming to the venous phase is mainly done to look for METs, look for nodes, look for the venous anatomy and venous relations to the mass. Now that we understood the importance of pancreatic phase and a venous phase, now we'll look at how does the mass look on a dual phase CT. So we can see here that you can see an irregular, ill-defined hypoenhancing mass looking in the situated in the head/uncinate process. And in this image, we can see that the pancreatic duct is dilated. As I've already explained, a PDAC will cause obstruction of the pancreatic duct, causing atrophy of the surrounding parenchyma. Along with it, it can also cause obstruction of the common bile duct, coming to you with a double duct sign. However, post contrast, you will see that the mass is either iso to hypoenhancing, and on a delayed phase, you will see gradual progressive centripetal filling in. right? Now we'll move forward to MRI, which is more sensitive than CT. On an MR, we can see that it is hypointense on T1. On T2, it can be hypointense or it can be mildly hyperintense. So you can see this signal, it is mildly hyperintense, showing intense diffusion restriction. And on contrast, it's similar to CT, where you'll see a hypoenhancing mass which shows delayed gradual centripetal filling in. As we can see, there is centripetal filling in. Now we have understood the imaging carcinoma. As a radiologist, our work doesn't end here. We have to tell the surgeon what are the various relations and the extent of pancreatic ductal adenocarcinoma. There are 5 types of relations or extent you need to talk about. Starting with the local, the neural spread, the vascular relations, the nodal, as well as the mets. We'll start with local. Locally, you need to look at the duodenum, you need to look at the bowel loops. We already know we are looking at the pancreatic duct, we are looking at the common biliary ducts, that is the CVD. Moving forwards to the neural spread. There are 3 tumors which show neural spread. One of it is pancreatic ductal adenocarcinoma. Obviously, we are reading it. The other 2 are cholangiocarcinoma and periampullary carcinoma. Neural spread, there are of 2 types, type 1 and type 2. Type 1 is along the celiac axis, type 2 is along the superior mesenteric axis. So, if you're seeing neural spread along the celiac axis, look for a PDAC in the pancreatic head region. If you're looking at a soft tissue along the superior mesenteric artery, look for a PDAC in the uncinate process, right? Now we look at the example. So, you can see that there is a sheet-like hypoenhancing soft tissue on either side of the superior mesenteric artery, which indicates neural spread. Why are we seeing along the artery? Because superior mesenteric artery and celiac artery will have plexus around it, the neural plexus, through which PDAC would be extending, and hence you will see this soft tissue, right? Moving forwards to the nodes, we have regional and non-regional, regional being peripancreatic and celiac, non-regional include all other nodes except these 2, peripancreatic and celiac nodes, right? Do we call any node as involved? Because even in normal patients, you will be seeing a para-aortic nodes which are present. So do we call them involved? No. Only if it is meeting these criteria. If it is more than 1 centimeter or round in shape, or if it is heterogeneous in nature, these 3 criteria will tell that this node is a suspicion for the spread of malignancy. Moving forwards to the mets, most commonly it is spread out to the liver, as we can see in this case, where you can see multiple liver metastasis, and then peritoneal nodules can also be seen. Now, vascular relations we'll understand with the resectability criteria itself. There is a recent update in NCCN and it gave out a new resectability criteria in 2024. It is slightly difficult to understand, but we'll simplify it. It is dividing the resectability criteria into 4 parts: resectable, borderline resectable, locally advanced, distinct mets. Distinct mets, we already know it would be non-regional lymph nodes and metastasis. Now, we are left with 3: resectable, borderline resectable, locally advanced, right? There are 2 rules to understand this resectability criteria. Rule number 1, you need to look for relation of 5 vascular structures, 3 arteries and 2 veins. The 3 arteries are superior mesenteric artery, celiac artery and common hepatic artery. The 2 veins are superior mesenteric vein and portal vein. Rule number 2, vein is always first, right? Now we look at the criteria. If you are saying the PDAC is resectable, it should have no contact with the artery, or no contact with vein, or less than 180-degree contact with SMV or the portal vein. Coming to borderline resectable, we know vein is always first. So it started with less than 180-degree, now it will progress to more than 180-degree contact with superior mesenteric vein or portal vein, right? But the distance of involvement should be less than 2 centimeters. So if this is your superior mesenteric vein, the PDAC is showing this much involvement and this length is less than 2 centimeters, it goes into borderline resectable. If it is more than 2 centimeters, it goes into locally advanced, right? Now we are done with the venous. Come to the artery. Artery resectable was no contact. Borderline resectable was from no, it goes to less than 180-degree contact with common hepatic artery or celiac artery or superior mesenteric artery. Now, what will be locally advanced? Obviously, more than 180-degree contact with common hepatic artery or celiac artery or superior mesenteric artery. Now, to call it resectable, borderline or locally advanced, it is not necessary that it has to follow both artery and vein. Either artery involvement or a vein involvement, still we have to include it into resectable or resectable or borderline resectable or locally advanced. Any one of it is sufficient, both are not necessary. Now we'll look at few examples to understand the same. So this is the first case scenario where you can see this is the pancreatic ductal adenocarcinoma. This is our SMV, this is our SM. There is no area of contact between the vascular structures and PDAC, so it becomes a resectable tumor. This is the second case scenario where you can see this is the PDAC, this is the SMA, and the angle of contact is less than 180 degree, so it becomes a borderline resectable tumor. This is a third case scenario where you can see this entire thing is PDAC and it is showing more than 180 degree contact. So this becomes a locally advanced disease. Along with it, you can see that there is a sheet-like soft tissue which is extending along the superior mesenteric artery. So this is nothing but a perineural spread. And this is the last case scenario where you can see multiple liver metastasis. So this is a distinct mets. Now we understood the resectability criteria. Now we will look at few variants of pancreatic ductal adenocarcinoma. Moving forwards to the variants of pancreatic ductal adenocarcinoma, whenever you're ruling out the three major solid neoplasms of pancreas, that is pancreatic ductal adenocarcinoma, pancreatic neuroendocrine tumor, pancreatic lymphoma, but still you are able to see a large mass sitting in the pancreas which is solid in nature, think of variants of pancreatic ductal adenocarcinoma. There are four variants, that is mucinous, anaplastic, medullary and hepatoid. Mucinous is a variant of adenocarcinoma anywhere in the body, and mucinous tumor anywhere in the body will be T2, intensely hyperintense, will show mild delayed enhancement, minimal diffusion restriction or no diffusion restriction, and patient will have a good prognosis. Anaplastic we know is very aggressive and it will have a worse prognosis. Coming to the medullary variant, it is associated with the polyposis syndrome, that is hereditary non-polyposis colon cancer. Right? Now that we understood the variants, we'll just briefly look into the treatment of pancreatic ductal adenocarcinoma, that is PDAC. If it is a resectable tumor, as we would give in our reports, if it is sitting in a head, do a pylorus preserving pancreaticoduodenectomy. However, if it is sitting in a tail or a body, go ahead and do a distal pancreatectomy and a splenectomy. If it is a non-resectable tumor, go ahead and do a neoadjuvant chemotherapy with gemcitabine and 5-fluorouracil, right? And then you restage the tumor with a DPCT. If it is a resectable tumor on restaging, right, you go ahead and resect it using the same criteria which I explained before. If it is non-resectable, then do palliative measures for a symptomatic relief of the patient. That is, if the patient is having jaundice, go ahead and do a PTBD. If the patient is having severe pain, do a celiac plexus block. Now, what is a celiac plexus block? Celiac plexus block is also something which is done by an intervention radiologist. It is typically done at the level of T12 to L1 level. Under ultrasound guidance, we put a needle in the para-aortic region and we inject some amount of lignocaine. This is very effective in causing pain relief to the patient. Now that we have understood how to treat PDAC also, now the patient has to be on a follow-up to check for recurrence. For that, we do two things. One is the tumor marker, obviously, that is CA19-9. Along with it, a radiologist will do a continuous DPCT to look for a recurrence. Now, there are two new tumor markers, that is TIMP1 and LRG2. Now that we have done with the follow-up of the patient, you need to understand what are the differential diagnoses of pancreatic ductal adenocarcinoma. We already know the solid pancreatic tumors will be the differentials. Along with it, there's one important thing which you need to rule out before giving PDAC, that is mass-forming chronic pancreatitis. We'll look at an example to understand this. So, in this first case scenario, we can see that there is a dilated pancreatic duct, right? And on an MRCP, you will see that this is this dilated pancreatic duct and there's an abrupt cutoff at this level. And this abrupt cutoff of a pancreatic duct is called as duct cutoff sign, which is very classic for pancreatic ductal adenocarcinoma. And there is a rule which says any duct cutoff sign of a pancreatic duct with associated pancreatic atrophy and you're seeing a mass, think of PDAC as first differential. In an NET or in a lymphoma, dilated pancreatic duct to this extent is less likely. They are a late features of those solid neoplasms. So if you're seeing a prominent dilated pancreatic duct, your first differential has to be PDAC over other solid neoplasms. Then again we can see here a solid mass in the head/uncinate process. On MRCP, however, you can see that the pancreatic duct is unaffected and it is opening in the ampulla of Vater, right? This is known as duct penetrating sign. So duct penetrating sign is a sign of chronic pancreatitis, whereas duct cutoff sign is a sign of PDAC. So this is the most important difference. What is the other differences? Presence of history of pancreatitis goes in favor of pancreatic ductal adenocarcinoma, whereas multiple history of pancreatitis is the cause for mass forming pancreatitis. So pancreatitis is a complication of PDAC. Multiple pancreatitis causes mass forming pancreatitis. Understood? Duct cutoff and duct penetrating we already know of. Presence of calcification goes more in favor of mass forming pancreatitis over PDAC, but however both can have calcifications. The other most important one is tumor enhancement. We already know PDAC will show hypoenhancement with gradual centripetal filling in, whereas mass forming pancreatitis will be hyperenhancing on post-contrast sequences. So guys, here we end the topic of pancreatic ductal adenocarcinoma. If you guys like the way of my teaching, it is a simplified way, please leave a comment in the comment box below. And if you guys have any suggestions about the topic I need to take next, so you can leave a comment in the comment box. Thank you.
Hey guys! If you like our simplified approach to difficult conceptual topics, please do comment, like, share, and subscribe to our channel.